Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Welcome to today's event on recent developments in nursing home care. There have been longstanding concerns regarding the quality of care in nursing homes, and those concerns were only exacerbated by the COVID-19 pandemic, when at least 40% of all COVID deaths were associated with nursing homes. But there have been similarly long-standing efforts to improve care in nursing homes through improved quality monitoring, oversight, and more recently, various efforts to increase the quantity and quality of nursing home staffing. Today's briefing is an important opportunity to reflect on concerns and to consider opportunities for improving care for the more than 1 million nursing home residents in the United States. This briefing combines what we like to do most at Health Affairs. You'll first hear recently published evidence regarding nursing homes, and then we'll engage in a policy-oriented discussion about the future of nursing home care. This event is part of our Age-Friendly Health series, which is supported by the John A. Hartford Foundation. We're grateful to the foundation for supporting the journal publications in this series and this event. So before I begin the discussion, it is my pleasure to introduce to you Terry Fulmer, president of the John A. Hartford Foundation. Dr. Fulmer is a nationally, indeed an internationally recognized leader in building better care for older adults. And I have to say, from my perspective, equally important, she's a creative and inspiring leader who I've had the pleasure of working with for many years. Terry, love to get some opening remarks from you.
Thank you so much, Alan. It's good to see you today. Health affairs plays such a crucial role in shaping health policy, and your team's expertise, rigor, and passion for publishing and disseminating the highest quality research and analysis helps all of us get the policy changes we need to make healthcare better for all of us. We're proud to have supported health affairs for over 40 years, and you've never let us down. And thank you for inviting me to today's serious and still troubling discussion on nursing home care. This panel knows well the lessons learned during and since COVID and the policy actions we need to move forward so that nursing homes are places in which lives are nurtured, residents are empowered, and where people want to work. Why is this so important to us at the Foundation? Our mission is to improve the care of older adults, no matter where they are and no matter who's providing the care. And we work to improve that care in our three intersecting areas, which is creating age-friendly health systems, and that system starts at your kitchen table and gets you back there, supporting family caregivers, and improving serious illness and end-of-life care, not to be conflated. Nursing homes touch all three of those areas, and while about 1.2 million people live in nursing homes today, nursing homes need to matter to all of us. These are homes for older adults and people with disabilities who have the most complex needs and who face the most vulnerability. And we'll hear more about that from our excellent speakers. They're a vital part of our healthcare system, albeit an often ignored part. And we know from our own polling that most people express grave concerns about nursing home safety, and they're unwilling to live in one, and that nursing homes need to change. One thing I always notice when we're talking about nursing homes is people say, "Did you put your mother in a nursing home?" These are not objects. People are not objects. We don't put anybody anywhere. Did you make that crucial decision to work with your family member to decide nursing homes were right for you? While the perception that nursing homes needs to change is not new, but was strongly reinforced during the pandemic and when our foundation made emergency grants to support weekly huddles on topics like PPE and infection control, all of you on the screen were with us in helping. We accelerated the production of the National Academy of Science, Engineering, and Medicine report on nursing home quality, the first one in 30 years, that now serves as a comprehensive blueprint for improving care today. And we know people want nursing homes to change, and we can do that. We can change nursing home care if we follow the data and the science and listen to experts, including those who live and work in nursing homes every day. The Health Affairs Age-Friendly Health series is helping us do this, follow the data, the science, and the experts. So our age-friendly series includes peer-reviewed research, open access commentary, narrative matters essays, and journalistic entry pieces. And the nursing home content in this series has been truly remarkable, and we thank Health Affairs. Today, we welcome some of the world's most distinguished researchers in long-term care, the advocates and the Centers for Medicare and Medicaid Services, which continue to ensure improvements in nursing home care. They all deserve our deepest gratitude. And with that, I really want to thank you for letting me say a few words of welcome, and I'll turn it back to you, Alan. Thank you.
Thank you, Terry. Thank you for the kind words. And it's been a really wonderful relationship with the foundation, as you say, going back basically to our first days at Health Affairs. So greatly appreciate it. We have a great session planned for you all. We have 6 terrific speakers who I'll introduce in a moment. To the audience, I just want to say, if you're watching live, you can submit questions through the Q&A tab at the bottom of the screen. I'll do my best to incorporate your questions into the conversation as time allows, and prefer your questions to be of general interest to a broad audience. More likely that I'll be able to weave them in if they are that. And also just to tell everyone that we are recording the event, and it will be available shortly on our website for viewing as well. So the way we're running the show today is we have our first 3 presenters are authors of papers published in the Age-Friendly Health series in Health Affairs. And they will present their papers, although they're also experts far beyond the content of their papers, and I have encouraged them to feel free to extend beyond the boundaries of their papers. And then, as noted, 3 speakers who I asked to use the papers as a point of departure as well. What issues does it raise for them? What do they see as the most important issues in nursing home care today and into the future? I'll introduce everyone now so that we can move through the panel directly. We'll just go from one through to the next. We're starting with David Grabowski, Professor of Healthcare Policy in the Department of Healthcare Policy at Harvard Medical School. He'll be followed by John Boblis, a Professor of Economics at the Farmer School of Business, a Research Fellow in the Scripps Gerontology Center at Miami University. Following John will be Tamara Konecka, Lewis Block Professor of Public Health Sciences and Professor of Medicine at the University of Chicago. As noted, these 3 have all written papers published in the journal in this series. You'll then hear from Kezia Scales, Vice President of Research and Evaluation at PHI. Following her will be Alice Bonner, Senior Advisor for Aging at the Institute for Healthcare Improvement. And we'll last hear from Jean Moody Williams, the Deputy Director in the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. So those will be our 3 policy respondents, if you will. Without further ado, I'll turn it over to David Grabowski to begin presenting the research that we've published in the series.
Great. Thank you, Alan, and thanks to the team at Health Affairs for putting this on today. And of course, thanks to the John A. Hartford Foundation for supporting this series. So as has already been mentioned, nursing homes have long struggled with producing high quality care. And I think the most important factor towards encouraging high quality nursing home care are the individuals working in these buildings, the staff. And historically, this predates the pandemic. Nursing homes have struggled to attract workers to this sector. And this was magnified during the pandemic with wide-scale shortages of workers. Next slide, please. There has historically been a real reliance on foreign-born workers. And I like to say that immigration policy is long-term care policy. And you can see that this is Exhibit 1 from our paper that we published. And I'll say this work was led by my colleague, Kate June, who is starting this fall at RAND. Kate and I showed that foreign-born workers have always been important for the nursing home workforce, but they took on a heightened importance during the pandemic, where a number of native-born workers, certified nurse aides, left the workforce. But foreign-born workers generally stayed in the workforce. And I like to say, think about where we would be if foreign-born workers had left at the rates that native-born workers had left this workforce. So today, foreign-born workers are more important than ever before. And as you can see on this next slide, there's a real correlation between the share of certified nursing assistants who are foreign-born and the overall size of the workforce in that state. So you can see along the x-axis here, this is just the percent of certified nurse aides who are foreign born. And you can see the highest shares there are California and Hawaii. And then you have states like Louisiana, Mississippi, and West Virginia on the left there that are quite low. And that dashed line there suggests a positive correlation. The more individuals you have, the greater the share of your workforce that are foreign born, the larger that workforce. So these workers are really, really important towards expanding the number of workers. They don't crowd out jobs among native-born workers. They add to the workforce. So how do we fix this? On this next slide, you would think that we make it fairly easy for foreign-born CNAs to work in nursing homes, but we actually don't. Most permanent and temporary working visas are not really geared towards certified nursing assistants. The permanent visa categories like EB3 covers all workers, but only 10,000 workers annually across all industries. So this is just a tiny slice of the overall workforce. There are temporary visa categories like H-2B that largely covers non-agricultural work and most of that work outside of the long-term care area. Maybe there's a little bit of landscaping or housekeeping. If you can believe it, most individuals who are working in nursing homes as CNAs arrive through visa classes like asylum and family reunification. We're really not gearing our immigration policy to attract individuals to work in nursing homes. How could we change this? The U.S. has occasionally used different visa categories to grow the RN workforce. Why not try similar approaches with the CNA workforce? We could certainly try new visa categories, and we could provide pathways to permanent residency. We're not the only country interested in attracting foreign-born workers. We see these workers in Canada, all over Europe, and elsewhere around the globe. This is a competitive marketplace. And in a competitive marketplace, different countries are putting forward policies to attract potential workers. Canada has the fast track program where you can very quickly become a permanent resident. The US might think about similar approaches. Next slide, please. The final point I really want to stress here is that oftentimes I think people view immigration as an instead of, or this is a substitute to other policies that we might implement. Very much argue that immigration has to be complementary to other approaches to grow the workforce. I wrote back in 2021, we need to fix nursing homes. Where do we start? A lot of these ideas, as Terry mentioned, actually showed up in that National Academies report. But there was a whole set of ideas. We need better pay and benefits, minimum staffing standards, and obviously the Biden administration has gone forward with that policy. We need to raise reimbursement rates, ensure that those dollars are making their way to direct care workers in terms of increased financial accountability. We need to allow workers to advance within nursing homes, and finally, we need to improve working conditions. So I would very much view immigration as part of a larger package of reforms. I'm not trying to grow the workforce through only immigration, but I would assert immigration can be a big part of growing this workforce broadly. Thank you.
Thank you, David. We'll now turn to another take on staffing from John Boglis.
Thank you for having me. I want to acknowledge my co-authors who have put a lot of effort into this particular work. And what I'm looking at, or what my co-authors and I have looked at, is nursing homes and the use of agency staff. And so if we think about nursing homes, the most important type of staffing is direct care staff, specifically for nurses. And these are the people who are providing hands-on care, but also looking at the patient clinically. Most nursing homes would like to employ directly hired employees. The reason being is that they can be aware of who those employees are, what their educational background is, what their training is, what their competency is. But there are times that they have to rely on temporary staff who come in from other companies. We call this agency staff. What's important about this is that agency staff has always been used by nursing homes and in healthcare when there's been sort of a need for that. Say somebody gets sick. However, the pandemic has really created a large labor disruption, and nursing homes had to require or use agency staff on a more regular basis. And so what we wound up doing in this study was to sort of understand how agency staff use changed over time. If we go to the next slide, which comes from our paper, what we've looked at is what is the percentage of nursing staff that is directly caring for residents that comes from agency staff. And prior to the pandemic in 2018 and 2019, about 2 to 4% of all hours of staff time was coming from agency staff, meaning that most of the interactions with residents were from directly employed employees. Starting around when the pandemic got really bad in terms of the number of cases in that sort of December of 2020, we started seeing a large uptick in the use of agency staff of nursing homes, and it continued and sort of plateaued into 2022. By 2022, about maybe 10 to 12, 14% of nursing homes hours for nurses were coming from these staffing agencies. But it's important to understand that it's a large mix. Some nursing homes still used very little, but there's other nursing homes where 60% of the hours were coming from agency staff. And if we go to the next slide, we can also see how that agency staff had changed. What we're seeing here on the left in the teal colors is what was the number of days that nursing homes tended to use agency staff, and about 25% of nursing homes were using agency staff maybe 1 to 30 days in 2018. That's sort of consistent with this idea that somebody called out, was sick, maybe they decided to leave for another job and you needed somebody to come and temporarily come in. But by 2022, which is in these orange bars, we see that they sort of are rated to the right, which is these nursing homes are using agency staff almost every single day. And so there's this huge change in sort of the dynamics of how agency staff is being used. And this had significant financial consequences. If we go to the next slide, what we have from our paper is sort of what is the median wage rates of directly employed nursing staff versus how much is the nursing homes paying staffing agencies. And it's always about 50 to 60% more than the directly employed individuals. But if we go all the way to the right, we can see that the growth rate in how much is being paid to agency staff per hour was a lot higher than if you were looking at directly employed workers. And so this has significant consequences for nursing home operations, which are summarized on our next slide. But in particular, what has happened is we have a huge increase in agency staff, which increases the cost to the operator of running their nursing home. And at least in the beginning of the pandemic, a lot of these costs could be offset with public health emergency funds. But as those public health emergency funds sort of ended in 2022, if states didn't offset these costs with higher Medicaid reimbursement rates or higher Medicaid payment rates, what happens is these facilities are going to have less financial resources to devote for staffing. So something has to be cut. And that's either staffing levels on nursing, or it could be cutting other things like activities, social services, or other operations. The other thing that we're really concerned about is that use of agency staff can have an effect on the morale of existing staff in the facility, and that may lead to higher turnover. So going back to the actual patients, what we're really concerned about here is that agency staff use could lead to potential harm. In particular, the use of agency staff may lead to a less stable workforce. Stability, we know, is a key important factor. Even if we go back to CMS's original staffing studies from 2001, it talked about while staffing levels are important, there's a lot of other things that are important, like staff stability, turnover rates, and retention of staff. Another thing that we're concerned about is this concept called consistent assignment, which is if I'm a nursing home staff member and I work every day and I see Miss Jones every single day, I get to know Miss Jones's preferences. And if I see Miss Jones, have a change in her physical or mental or behavioral aspects of her everyday life, I may be able to identify those things earlier. Whereas if I'm an agency staff and I'm somebody who's new every single day, I may not observe those differences. And that can lead to sort of health issues being identified later in the residency and maybe leading to a hospitalization that's not necessary. And then finally, at least from the perspective of a nursing home, there's an access issue, which is there's a lot of people who are being discharged from a hospital after a short hospital stay. And we're getting reports about nursing homes that are not being able to admit those individuals because they don't have enough staff to staff the building. And so I think going forward in terms of a policy context, this has significant consequences for the new minimum staffing standards that CMS has implemented, which, yes, higher staffing levels is an important component, but I think we have to think about that staff composition, right? As I like to say, there could be 6 people there with one person with a shovel. It's not going to get any faster done than one person with a shovel, right? So the concept here is if the staff, the agency staff that we're using to fulfill those requirements are not motivated, they're not caring for the residents properly, it may be the case that we're not going to, do what we want to, which is have more staff that are really caring for residents and doing what's best for them. And so I thank you for your time.
Thank you so much, John. Finally, from our paper presenters, we'll hear from Tamara Konecka.
So part of the reason that we're paying a lot more attention to nursing homes these days is because of the experience in nursing homes during the pandemic. And so maybe that kind of attention is a good thing. But I think it's important to look at what we really learned given the evidence about policies during the pandemic. In the July issue of Health Affairs in the Age-Friendly Health series, I and my co-authors, David Grabowski and Vince Moore, wrote a commentary where we reviewed the evidence on what happened during the pandemic with an eye toward identifying lessons learned and what we might change moving forward. Next slide, please. So just to get everybody's mind back into what was happening during that first year or two of the pandemic, we know the public health emergency started in March 2020, and that's when nursing homes were locked down, visitors were banned. We started having data to look at this in very late May 2020, which was great and really facilitated this research. But during all of 2020, we saw nursing home case rates and death rates just sort of continue to increase, move from area to area. And a lot of policies were being implemented that during that time, sort of best practices were being identified in terms of testing and PPE. There were shipments of PPE and testing being sent out from the federal government. There was a crackdown on infection control and inspections to promote infection control. And so that was a lot of what was happening during 2020. And then in late 2020, vaccines emerged. And in early 2021, or very, very late 2020, we had the Pharmacy Partnership for Long-Term Care Program, which got nursing home residents and some staff vaccinated. And so there we saw, as you can see on this graph, a large drop in deaths. And then, that held steady for a while until about a year later when the Omicron variant emerged. So just to sort of review what happened there, there was a lot of uncertainty about which policies we're implementing and what might work. Next slide, please. Our review of the evidence showed that a lot of the things that we might really think would be natural solutions to what was happening in nursing homes turned out to have little or no effect. I'll start on the right side of this chart, or on the right side of this slide, with those kinds of policies. And these, you might think, were sort of self-evident, right? So one of these was regulatory focus on infection control. We know that infection control is very important in nursing homes, and that not a lot of nursing homes had deficiencies in this area prior. But the crackdown on infection control and efforts to improve it didn't really have a lot of effect. Similarly, policies that provided assistance in the form of performance incentives, sort of giving more money to nursing homes that held down their case and death rates, also didn't really have an effect. Surprisingly, staffing only had a modest effect, and this was really a complicated area. We all know how important staffing is. You know, a lot of this discussion is about the importance of staffing and the nuances of staffing. But in terms of the pandemic, it was kind of a mixed bag in that having more traffic in and out of the facility actually could lead to a higher probability of an outbreak. Once there was an outbreak, having enough staff could help modestly to mitigate the number of deaths. There was also no real evidence that emerged, and here we just don't have a lot of evidence, but there was no real evidence that visitor bans really worked to hold down COVID rates, especially because staff did have to go in and out every day. Turning to what did work, the Partnership for Long-Term Care that basically got the vast majority of nursing home residents vaccinated in early 2021 had a clear effect, led to a clear drop in the number of nursing home deaths. And then somewhat similarly, mandating staff vaccination, not just sort of voluntary efforts to get staff vaccinated, but mandating staff vaccination really helped. This graph shows the effect I alluded to about the vaccination program, the Partnership Vaccination Program. Prior to that, in most of the first year of the pandemic in 2020, what we saw was that nursing home death rates closely matched death rates in the surrounding community, right? No matter what policies we were implementing, if a nursing home was in a virus hotspot, it was likely to have an outbreak and deaths, right? And so it was really the vaccination program in early 2021 where we finally saw a break in these two trends. And even though community rates were still skyrocketing, nursing home deaths were dropping. Next slide, please. Okay, so a couple of big implications of what we found. The first one, and again, I think this comes as a surprise to a lot of people who have been thinking about nursing homes, but our first general conclusion was that the common assumptions about the nursing home sector, assumptions about, for example, that this is, largely a for-profit industry that would prioritize profits over, resident welfare in the face of a pandemic. That kind of narrative turned out to be insufficient to really explain what was going on during the pandemic. And in fact, what we found is that consistently in the strongest studies, the biggest predictors of which facilities had more deaths was just community spread, where the facility was located, and the facility size. And there was really no strong association in the best studies with quality or ownership or even infection control practices. So this brings us to two sort of broad implications. We can think about staff vaccination, we can think about more staffing, we can think about federal programs for vaccination, but those are all going to sort of incrementally help. And what we really need here is not these policies that will address a bad apples quality problem, but rather larger systemic interventions. One of these would be to integrate long-term care better into public health planning. What we see consistently is that state, local, and federal disaster plans, public health plans ignore long-term care. And it turns out individual facilities, without being integrated into a bigger plan, are not well equipped to handle a disaster the size of COVID. The second main implication is that we really need to think on a broad level, rethink the physical structure of nursing homes. There are models like the greenhouse that seem to fare a little bit better during the pandemic, that provide a smaller, more home-like structure and more flexible staff roles. And those are designed to improve quality of life, but it turns out there's also a benefit for infection control. And I'd say finally, what we learned from the pandemic is that it's really important. This is where nursing home residents live. It's really important to keep a better balance of physical safety with quality of life and not prioritize physical safety while experiencing the sort of unintended harms of physical isolation. Thank you.
Thank you so much. So now that we've heard our three paper presenters, as noted, I've asked three folks to provide some reaction to the topics raised here and other issues that they see as critical around nursing home future. I'll turn first to Kezia Scales.
Thank you so much for the opportunity to join this panel alongside such leaders in this topic. I'm coming to this conversation from PHI, which is a national organization that focuses on the direct care workforce across long-term care settings, including nursing homes and home and community-based settings. And everything that we do at PHI is about promoting quality jobs for this essential workforce as the foundation of quality care for older adults, people with disabilities, and people with serious illness. So, of course, in my remarks, I would like to further emphasize the absolute critical importance of considering the workforce in nursing homes as we reflect on recent developments, assess current conditions, and aspire to the future. Nothing else is possible. I know you've heard this already, but I really want to underscore it, that nothing else is possible in terms of achieving high quality, person-centered nursing home care without a strong and stable workforce that's well prepared, supported, compensated, and respected. And I would argue that that applies to all nursing home staff, but CNAs in particular as the linchpin, because they are the majority and they are the ones that spend the most time with residents. And they are the ones that get to know residents and their histories and their preferences and idiosyncrasies and signs of well-being and ill-being. And so there are three discussion points that I would like to pull out here in particular, one from each of these remarkable papers. First, in response to Dr. Grabowski's work, I want to underscore how vital immigrants are within the direct care workforce in nursing homes and indeed across long-term care settings. And I want to emphasize that as we're thinking about immigration policy implications and opportunities, we're thinking not just about how to fill jobs, but how to support the inclusion and success of immigrants in caregiving roles. So that means ensuring that immigration policies support employment rights, safeguard against exploitation, and as mentioned, wherever possible, provide pathways to citizenship. It also means thinking about complementary policy changes to expand eligibility for public assistance programs like Medicaid for those who are currently categorically excluded, because for many nursing assistants and other direct care workers, these assistance programs are critically needed to make ends meet. It also means policies that allow training and certification in languages other than English and other targeted and tailored strategies to support the recruitment and retention and well-being of immigrants in this workforce. Moving to the second paper, Dr. Boblis's quite startling findings about increased agency staffing rates in nursing homes and the potential implications at every level. What I want to pull out two key takeaways here. The first is that we must use every policy and practice tool available to improve nursing home jobs, directly employed non-contract nursing home jobs, so that job seekers and existing workers can choose and sustain these jobs. And second, I think that we really need to fund and conduct more research to better understand what's going on within the contract staffing trend in nursing homes and its association with care quality, so that we can home in on the right policy strategies to slow down or even reverse this trend on the one hand, but also to identify the right policy and practice interventions to support the mixed workforce that we now have, and will continue to have. So in other words, it's not an all or nothing situation. It's about determining how we can reduce contract staffing reliance and how we can support and empower a workforce that includes contract staff to deliver the best possible care. And third, and finally, in response to Dr. Konecka and Dr. Grabowski's paper, I really appreciated that paradigm shift thinking about what needs to change in order to see better outcomes in future crises. And I would like to suggest that better staffing is one of those structural systemic changes that are needed, rather than a sort of quicker or interim fix, because we know from such a long history of workforce challenges that better staffing also requires transformation in how we perceive and talk about nursing homes and nursing home jobs, as well as how we finance, regulate, and manage them. But also, I think what is exciting is that a byproduct of the major changes that Dr. Konecka suggested would be improved staffing, because those changes would lead to safer, more integrated, smaller, more person-centered nursing homes where people are more likely to want to live and to work. And I do want to take that integration argument that Dr. Konecka made as a jumping off point to make one further and sort of more ambitious point about the direct care workforce and better integration across the direct care workforce. So PHI publishes a detailed profile on the direct care workforce every year across long-term care settings. And our report that will be released fairly soon estimates that there are just under 460,000 CNAs working in nursing homes across the country. But there are about 5 million total direct care workers across long-term care settings, including but not limited to nursing homes. And there are workforce shortages and challenges across those settings. But so many of our workforce policies and practices occur in silos. So we have one workforce development program over here designed to recruit more CNAs into nursing homes. And over there, an effort to incrementally raise wages or improve training for home health aides. And that leads to a patchwork of efforts that don't necessarily meet the needs of this workforce or the health and long-term care system. So my concluding point here is that we should be thinking in more integrated, coherent ways about the direct care workforce as well, with regards to training and credentialing, career ladders and lattices, wage floors and wage progression, and more, with the goal of ensuring a strong, stable, and flexible workforce that's prepared to provide high quality post-acute care and long-term care to all those who need it when and where they need it, in nursing homes and across settings of care. So thank you again for the opportunity to participate in this important conversation.
Thank you for those comments. I'll turn now to Alice Bonner.
Great. Well, thank you so much. Very, very glad to be here with everyone. And that was a wonderful jumping off point, Kezia, for the next conversation that I'd like to have with everybody. So in addition to my role as Senior Advisor for Aging with IHI and the Age Friendly Health Systems team, I also chaired the Moving Forward Nursing Home Quality Coalition, which is also generously funded by the John A. Hartford Foundation. And along with our director, Isaac Longobardi, our task was actually something very relevant that other speakers have already talked about today, which is that the National Academies of Sciences, Engineering, and Medicine report on the national imperative to improve nursing home quality. I will say I have my own copy here, and it's got a lot of Post-its and dog ears because it's never very far from my desk. But, you know, that report, as David said initially, has 600 pages of recommendations. And there was a fear that, you know, if people didn't come together and talk through that and figure out how to act now together with diverse organizations and diverse voices coming together powerfully to say, what can we do now, that the report would just sit on a shelf. So again, the Moving Forward Coalition was tasked with really doing detailed review of the report and then coming up with just a handful of those 600 pages of recommendations, and then creating action plans so that we can really begin to do work now related to just a handful of very focused efforts. And the reason I'm mentioning that specifically today is all three of the articles focus on issues that have been discussed often and by many national experts through the Moving Forward Coalition's committee work and the work of their steering committee. So maybe first I'll just pick up on what Kezia was talking about as well, work that PHI and other organizations have done on staffing. And the papers, all three presenters talked about staffing as well. In our next phase of work, which again, we were just generously funded for another 3 years, we're going to work with the Geriatric Workforce Enhancement Programs, or the GWEPs, as they're sometimes called. They're funded by through HRSA, federal funding, and any of those programs that are working on registered apprenticeship programs for CNAs, certified nursing assistants, who would be likely to work in nursing homes. Our committee members and advisors are going to work with those GWEPs and provide support, advice, and guidance, and we're going to work very closely with the GWEP Coordinating Center. So again, that's a very specific action that the Moving Forward Coalition is taking, and we have 1,600 people from all over the country who've signed up on our website. So this is not myself and our director doing this work. This is lots and lots of people across the country, and staffing comes up every single week, every single day. There is no question about it. Then, we also heard panelists today talk about coordination and integration, integration within nursing homes of team members. Kezia talked about CNA integration. That's very, very important. It's also critical that we have integration across settings. So, very often, and Tamara mentioned this too, that, the multi-sector plans on aging that are the state plans for aging programs and services. Some of them do mention nursing homes and nursing home programs, but a lot of them don't. And so people who live and work in nursing homes and family members and advocates may feel that they're just not being recognized. So we can do better with that. And more states are trying to do better bringing nursing homes in. But in terms of that integration, one of the other things that we found out when we were doing our work over the last 2 years was that when people come from the hospital or home and enter a nursing home, they don't necessarily have their goals and their preferences outlined, and that documentation doesn't necessarily come through. So we have a whole program over the next 3 years. It's going to be led by Kansas State University, working with 5 nursing homes, and they're going to be bringing a guide and a process that Moving Forward Coalition members brought together, and they're going to be testing that. And it's all about communication. What do residents want? What matters to residents themselves? And how can we pull that together so everyone who's involved with those residents knows what their goals and wishes and priorities are? And then the third priority project for us going forward is, again, about amplifying the voice of residents. People sometimes ask a family member or a nurse practitioner or someone on the team about what really matters to them in their daily life. And strengthening resident councils is the third approach that we are rolling out. And we're going to be working with the state of Connecticut and a group of nursing homes there. And ultimately, we would like to have statewide a statewide approach so that all of the nursing homes in Connecticut are running resident councils the way they would like to. So again, I'll just kind of wrap up by saying all 3 of these papers get at critical core issues: staffing, person-centeredness, and knowing residents, and having a really strong team and involving everyone in a non-hierarchical way. The answer cannot be that, certified nursing assistants are too busy with residents to be able to come to care plan meetings, to be able to contribute what they know about residents. I imagine that a lot of the people on this call are nodding their heads when we all talk about that, but it's critical that we get as many nursing homes as we can, of the 15,000 or so, and really make sure that there's consistent and standardized approaches to running these programs. So once again, I'll just say, if you're interested in learning more about the action that we are taking now, and everyone on this panel is part of that, and Health Affairs is a part of it, please go to the website for Moving Forward Coalition if you're interested, and you can see more about our work there. But again, many thanks to Health Affairs and the John A. Hartford Foundation for supporting our work as we go forward. So with that, back to you.
Thank you, Alice. And I'll turn now to Jean Moody-Williams.
Thank you so much, and for inviting me. And I'm really honored to be here with this distinguished panel. As been referenced before, I've worked with many of them throughout my career. You know, and as we look back and we are reminded that the COVID-19 pandemic was just such an unprecedented event, in which the science was really evolving as we were making real-time policy decisions. And we didn't have the benefit of controlled randomized studies all the time, or retrospective reviews such as those described today. But so these studies from all of the authors will be valuable as we move forward and think about future solutions for better care for residents, for sure. My comments today will fall into two areas, really resilience and workforce, and they are both obviously related. On the matter of resilience, I want to first stop and thank everyone that worked through the pandemic, as your efforts were truly valiant, and we worked through that over the course of several years. Secondly, I'll note that there's little disagreement with several of the findings from the papers that were presented today, particularly on the lessons learned from the COVID-19 pandemic in U.S. nursing homes. In fact, CMS completed a mixed method study entitled Learnings Regarding Emergency Preparedness During the Public Health Emergency. It was published in August of 2022 in the New England Journal of Medicine Catalyst, that found that local planning and coordination was a critical driver in response to COVID-19. Providers emphasized that local coordination during the pre-PHE planning generally led to a higher quality emergency preparedness programs and better response. And we published similar findings in a National Academy of Science and Medicine publication. Now, from a policy perspective, CMS is acknowledging that nursing homes should be included in local emergency preparedness efforts, and frequently they are not. And so we consider this as we update our emergency preparedness policies. Secondly, we agree with the importance of recognizing community prevalence in the pandemic. It became evident when we considered that residents were, for the most part, stationary during that time, and that there were relatively few visitors. There had to be a connection from staff that were coming in and out of the facility. And while CMS and CDC's efforts were directed at supporting staff early on, the availability of the vaccine became an essential tool to addressing the pandemic. It was then that CMS pursued the mandatory staffing vaccination rule. And so all of that was and will continue to be considerations in policy, but we must also continue to consider community efforts and future efforts. As one of the authors referenced in the Lessons Learned article presented today, they noted that nursing homes in denser, less white neighborhoods with more public transportation had a significantly larger outbreak of COVID-19. So there are deeper policy implications regarding equity that we must continue to address. Now, as it relates to the impact of infection control and technical assistance, we've recently completed a study soon to be published that noted that resident COVID-19 incidence, mortality, and hospitalizations were approximately 25% lower, and staff incident 19% lower in targeted homes than in non-targeted homes for those that worked and had the advantage of the QIO interventions. So more to come on that. Related to workforce, I think few of us would deny the importance of having adequate staffing. A major component of the President's action plan for nursing home reform, of course, centered on minimum staffing standards of nursing homes. And we know for the first time that CMS's rule established national minimum standard requirements, the 24/7 RN coverage, facility assessment, and the like. And as you know, The requirements will be phased in and there will be exemptions that are built in. A fact sheet recently published by ASPE, published in May 2024, noted that 50% of nursing homes already are staffed at or above the 0.55 registered nurse level, and 59% staffed at the 3.48. But as previously mentioned, and our last discussant mentioned, there's a gap when it comes to nurse aides. 30% of the nursing homes staffed at or above the 2.45 HPRD for nursing aides. So CMS announced that the agency will be investing initially over $75 million to launch a national nursing home staffing campaign to increase the number of nurses in nursing homes. We're working closely with HRSA. Great to hear Alice talk about those other efforts that are going on, and so that we can all work to improve the workforce. So again, I appreciate the discussion today. I think that we will continue to learn for several years to come. But the important point is that we put these learnings into action through both public and private efforts to ensure the best experience possible for residents, families, and caregivers. Thank you.
Thank you so much. Thank you all for really exceptional presentations, very thoughtful and very informative. I'm going to make my life a little difficult because I'm going to ask some fairly broad questions, and you all are going to have to raise your hand or jump in, and I'll try to coordinate. We've gotten some terrific questions from the audience. I also want to thank the audience for submitting such important and interesting questions. I want to begin with a theme that actually I think picks up, Jean, on where you left us. We can either do this at the detail level or at the more conceptual level, but there are new staffing ratio requirements, and there has been longstanding desire to increase staffing in nursing homes. And yet our first two papers presented, I would say, different dimensions of of staff shortage issues, whether it's related to immigration, whether it's related to agency staff. All of them are signs that the workforce is not as robust as it might need to be. And of course, Kezia, among others, discussed some of the barriers to having the workforce that we want. And the common thread in most initiatives to try to improve the workforce is better working conditions, which include salary, benefits, and everything else. That has cost implications, which create resistance, whether it's from industry or from public payers that are the primary source of payment. So I want to ask sort of as I say, it's a broad question, but it just feels like sort of the central question moving forward, which is, how do we think about the tension between the goals of increasing staffing to improve quality, which we know we need to do, and the a resistance to paying more for services that are already, to those who have to pay for them, seem quite expensive. We can argue whether or not they're priced appropriately, but they're certainly difficult to afford. What are the mechanisms for addressing this tension is the question I would ask, and I would open it up to whoever wants to start. Alice, it looks like you want to jump in.
I'll start, and then I'm sure everyone wants to jump in on this question. It's a great question. I would say this is really a public health issue. And, I had it in my notes to say more about public health, and I didn't get to, but Tamara and others spoke about this. We cannot say that that it's just okay to leave things the way they are, because it is going to cost more money to cover the cost of increased staff. But also, people on this call can jump in and say how it's maybe not going to cost as much. In some cases, you cited the nursing homes that are already staffed, per the minimum staffing. But, there is an equity issue, again, depending on which sources you read. Something like 60 to 70% of the payer source for residents in long-term care in nursing homes is Medicaid. And so these are individuals who do not have a lot of money. They're poor. And so there's an equity issue. We can't just say, well, we're not going to staff up in nursing homes if the need is there. So I would just say, I think it's a public health issue and an equity issue, and I'm interested in what my colleagues think.
Well, I know I'll just speak up and say, as I kind of ended, it is going to take an investment and working together. I'll say that there's a diversity of opinion. We got 46,000 comments on the nursing home rule. Some saying we've gone too far. Some saying, what are you kidding? You didn't go far enough. And so we're going to have to come together on this and work together to look at what the solutions are, including investments, ensuring that the investments get to the right place, and looking at all of these issues together. Thank you.
Maybe I'll jump in really quickly. Both Tamara and I sat on that National Academies committee, and we recommended a broad set of reforms, Alan, not just minimum staffing, but rethinking all of this. So I would advocate we need to take a very holistic approach. And just to build off of Jean, I'm glad, Jean, you read those 46,000 comments and not me. But I do think that this tension really speaks to not everyone agrees on a common set of facts here. And there's a group that thinks nursing homes need more money, and there's a group that thinks nursing homes have plenty of money and are kind of hiding it in different parts of the company. And it suggests to me that if we're going to get everyone on with a similar set of facts, we don't just need more money, we need more transparency. And that's something we've talked a lot about in moving forward and elsewhere, Alan, that without a common set of facts, it's going to be really hard to break this kind of stalemate, because there are a lot of strong opinions right now, some of them that nursing homes are making plenty of money, some of them that nursing homes need more money, and we really need those data.
And that's probably a good place for me to jump in as well. I would say that the fact that we're talking about increasing staffing, the fact that we have the CMS rule out there, I think is great, is a great start, right? I'm so glad we've gotten to that point, because I think everybody on this call and probably everybody listening agrees that, more staffing is fundamental. I think that a couple of the things that David mentioned about these sort of competing explanations for why we have low staffing now, I think those can all be true at the same time, right? I think we can say that, Medicaid rates are really low, and that it's hard to provide the level of staffing and the level of quality we'd all want based on those Medicaid rates. And I think at the same time, it's true that we need much more transparency, and that there are profits that are being hidden in very complex organizational arrangements, right? I think those things can all be true. Even if we probably, got rid of all of these odd ownership arrangements and really use the public dollars we're spending, maybe we would meet the public dollars we're spending to sort of meet a minimum level of care. I think that's what we get. We get a minimum, right? We get much more compliance. And is that really what any of us wants as we age? Do we want sort of a minimal level of compliance, in a large medicalized nursing home where the quality of life is not very good? So I really think that, we can debate how to get the higher staffing levels, but what we keep coming back to, it's what we came back to in the National Academies report, is that we need to really fundamentally rethink this, right? We need to fundamentally rethink reliance on Medicaid, which causes all kinds of disparities and inconsistencies from state to state, and constant struggles with other priorities that states are facing. We need to fundamentally think how we're probably completely underfunding long-term care, right? And so I think everything we're doing in the meantime is good in terms of trying to increase staffing. And what we're going to get is hopefully some incremental change without more fundamental restructuring.
Kezia, I think you wanted to jump in from the very beginning.
So many excellent points made already, and I know there's other questions to get to. So I think I would just add, and I really sort of love the closing point from Dr. Konecka about the fundamental changes that are needed. I think I would just agree with everything that has been said. Also urge us to think about the cost implications of not investing in better quality jobs, and really thinking a little bit more holistically and comprehensively about all of the money that's going into the system, and how it's being spent and where it's being spent. And just a couple of examples is there is a very high cost of job vacancies and turnover. We should be calculating that as we think about upstream investments. There is a very high cost of the number of direct care workers who themselves are utilizing Medicaid and other public assistance programs because their wages are not high enough to achieve economic self-sufficiency. And there is a very, very high cost of the sort of more acute care outcomes that are associated with unmet ongoing personal care and health maintenance needs that are provided by CNAs and nursing homes and other direct care workers. So thinking about all of those different costs, I think, and it's very difficult to follow all those dollars and make those connections. But I say that here in this space because there are such brilliant researchers in this conversation. We do need to be figuring out how to better quantify the whole equation in order to underscore the sort of moral and social and interpersonal dimensions of better investing in those who support this critical social good of care for older adults and people with disabilities.
And maybe if I could add one other thing to Kezia's points just now. We're all talking about nursing homes. We're all familiar with this space, very familiar. This is our world. But when we go to Congress, when we go to a U.S. Senator or House of Representatives, somebody in Congress or state legislators, they don't necessarily have a deep understanding of what a nursing home is, how it runs, who works there. David's nodding. People think that there's registered nurses and doctors, a lot of them in nursing homes all the time. And that's just, we all know that's not the case, but who are certified nursing assistants? How are they trained? Who's supporting them? Retention is so critical. People have made that point here, but it's really about valuing everyone on the team and making sure everyone on the team is that their voice is heard. So I just think not everyone who's in a policy position or a decision maker knows what we know. And it's always important to start those conversations when you're sitting in someone's office by saying, tell me what you know about nursing homes. What do you know about who lives there, who works there, et cetera?
Well, this was a great, robust response, and I appreciate the different, I mean that genuinely. This is so many different dimensions of what it will take, and I do, I don't need to be the running commentary, but I particularly appreciate Tamara's point that it can be both true that, there needs to be more transparency, and that's not the only problem that needs to be addressed. That I paraphrase that poorly, but that really stood out for me. So let me take an equally thorny topic, since you all liked that one so much, which is to get again raised by a number of questions that came in. I'm sort of weaving together questions because I got so many, which is great. And it has to do with sort of the environment of enforcement and industry, sort of resistance to change. Having many decades ago been responsible for a Medicaid agency, I remember how hard it is to get resources at the state level to do the kind of oversight that everyone says is necessary. We have, it seems each generation, there's a set of scandals that lead people to say we're not doing enough here. And then we beef up the oversight, and then it begins to wane. And it does seem like we just sort of have a chronic underinvestment in oversight, while you all are also saying, wouldn't it be nice if we could move beyond the minimum? Oversight is really about just achieving the minimum. So are in the same vein of both thinking incrementally about what we have now, but also reimagining a better world, are there ways we could think about oversight that both improve our ability to assure that minimums are being met, but also move us out of sort of a compliance model that we know is always going to be trying to avoid the worst and not actually improving to the best? Again, I open it up to anyone who wants to grapple with these large philosophical questions. Jean?
I'm happy to start since
Please.
it's my world, but first, I agree. We need more resources. We've been, as most of you know, have a flatline funding for our oversight for a number of years, but we are being resourceful in how we use those funds to focus on areas that are most beneficial and need more oversight. But in my center, we have the entire, I say, spectrum levers of change as it relates to quality, because we have the conditions of participation. We do the interpretive guidance as well as the oversight, survey, and certification. So making sure those areas are better aligned, and we've done that over the past couple of years to get the efficiencies that we need as we wait for additional resources. In addition to that, we have the quality improvement organizations in our area. And so we've been trying to work with them. They have been focusing for the past several years on nursing home care and working on the ground in the nursing home. So trying to do that from a technical assistance perspective, but very importantly, I won't say more importantly, is then using the data, being more evidence in our approach and using the data to drive our efforts. I think we are continuing to work in that area. Thanks.
Other thoughts on this? John, please.
Yeah, I think it's important to think about this from a state level, which is sort of missed even with our discussion about staffing, which is each state has really oversight of their nursing homes, and that a nursing home has to be in compliance with not only federal, but also state regulations. And so a lot of the differences that we see in staffing, and whether or not you're for or against the staffing mandate, or whether you think it's too high and whether we can afford it, really comes down to what is your current state's minimum? What is your state paying? And how is your state survey process look? And, living in a state that's sort of more of the Central America, it's central heart of America, not on the coasts, there's a different priority here. And so the thing is every dollar that's spent on nursing home care is a dollar taken away from the state budget on education, roads, and something else. And when I look at the state survey system within my state, and having worked with state lawmakers and policymakers, a lot of things that they look at is, what is CMS willing to pay us? What is CMS's rules? And are we just basically in minimum compliance with CMS? And so in essence, I think it's CMS that needs to lead by, if we want to get past just minimum compliance, we have the regulators who are going in and surveying, just doing what's the bare minimum that CMS is requesting from us. And so I think it's sort of like, we need to think about that aspect in all parts of nursing home care, whether it's dealing with staffing issues or whether it's dealing with how do we make, the survey process better.
And if I may add something to that, I agree completely with a lot of what has just been said. I think that, we see a very vulnerable population in nursing homes. So there's always going to be a role for enforcement, right? I mean, I think we can't get around that because we don't want really bad things to happen to people who can't do much about it. But I think conceptually, as John just alluded to, I mean, enforcement can't really promote quality of life, right? We've been trying for 35 plus years, since OBRA 87, which was grounded in a conceptual model that really focused on quality of life, right? Same thing with the National Academy's report that we published 2 years ago. We keep talking about the importance of quality of life, and yet our main vehicle most of these years has been sort of enforcement, and those are just conceptually incompatible, right? And, how do we move beyond that? I think there's this role for enforcement and it should be adequately funded. But there are other things like competition and alternative payment models, and a lot of things that if we sort of set up the right fundamentals in the payment system, we might be able to encourage more quality of life, right? If we had a system of funding where that was a little more seamless between home and community-based care and nursing home care, and where, there wasn't this big sort of Medicaid cliff, but, most of the middle class actually had some access to a long-term care benefit, we might see more competition for those dollars, right? We might see different sites of care competing with each other. And I think we could, think about setting up alternative payment models that did try to incentivize quality then beyond sort of minimal enforcement.
Maybe I'll sort of jump in and add and build a little bit on what you were just talking about, and also what John was talking about, that a lot of this is at the state level. So I was director of the state survey agency in Massachusetts just for 2 years, but it was a really, really hard job, really hard job. And one of the challenges, I think, is, having been a provider for most of my life and a clinician, bringing together surveyors and clinician and owners and operators of nursing homes to have honest, transparent conversations is really hard because of the way that the regulations are set up. In the state of Michigan, moving forward, and the Alzheimer's Association were invited to actually give a presentation in their all-day joint provider surveyor training program. And, it was over 400 people, all the surveyors from the state, a lot of providers, quality improvement organization people, long-term care ombudsman, advocates, and others. And I'm just bringing that up because I do think it's really important that we get these diverse voices and people with very different perspectives and organizations with different perspectives together. That's one of the things that a lot of organizations are doing more of now. And this call today is an example. We have, federal government representatives, we have clinicians, researchers, and advocates, and others. So it's really important that we continue to do what everybody here has said, get out of our silos, come together, have a conversation. Even if we agree to disagree, that's okay. But we need to have the dialogue about this.
Just really quickly to jump in on that. I agree with the prior commenters. We need to spend more here. I think we probably underfund regulation, even though I know it doesn't always feel that way. I want to double down, though, on a second point that I don't think we always spend the money that we do invest in this very well. And there's a very, I think, poor sort of distribution of how we use our regulatory dollars. Are we actually investing in components that matter to the residents themselves? Are we consistent? I'm not certain we're doing a very good job of any of that. And I could point to whether it's the special focus facility. There's so many examples where I think we're really falling short with our current regulatory model. And we offer some innovations, if you will, in that National Academies report. Like, could you survey the bad performers more often and the good performers less often? That's a very simple idea, but there's a lot of these. And then the final point, to Jean's point, like we need to do a better job of tying kind of the regulatory side to the quality improvement side. And I think they often are very siloed. And I think, Alice, that was your point, but I just wanted to really make sure that that comes through. Thanks.
I just wanted to say one thing here, which I think is important about both of this. Like Tamara brought up the concept of quality of care, right? I think when you look at a nursing home resident, they care about what their life in the nursing home is. And what we're doing with CMS and in the Care Compare and the star ratings is really look at clinical things like, did this person fall? It may be the case that I am somebody who's prone to falls, but my preference is that I want to walk on my own, and more falls as a consequence of that. And so I think part of this issue is that when we look at regulation or we look at star ratings, we're not necessarily always measuring what's really important and how do we do that improvement. And I'll just give one more example. Like when something bad happens in a nursing home, in many states, they are supposed to immediately report it to the State Department of Health, and then they're penalized for it, right? Instead of using it as a mechanism to try to improve care so that this doesn't happen again, instead, now we have to go to legal defenses because there's a fear of a lawsuit or the regulators are going to come in and fine us. And so I think the thing here is we look at regulation should be more of a carrot and a way of improving things. And right now it's really more of a stick. And so I think those are the types of conversations that we need to have if we really want to reform this type of industry and do what's best for residents.
Well, once again, I'm glad I asked a broad question because you took it in so many different directions that are really thoughtful. I appreciate that. I have a lot more to go through, and we'll just do what we can in the 15 minutes we have remaining. There have been a number of references to scale, the size of the institutions. One member of the audience, right as Tamara, you put up the slide about the deaths, put 6,000 per week. How many could have been prevented if residents had lived in smaller models? This is something, again, that has been mentioned in a number of contexts, both in terms of the infection control side of it, but also the resident satisfaction and staff satisfaction. Where are we in that? I don't want to call it a new issue, but it's probably less ripe than some of the traditional sort of nursing home reform issues. Where are we, and what can we do to catalyze that movement if it really is taking hold?
So
David.
I'll start. Alice, you probably know what I'm going to say. So both Tamara and I sat on the payment and financing working group for moving forward, and one of our we started with maybe some of the more traditional pathways like staffing and talking to CMS, and we actually ended up talking a lot to HUD, Housing and Urban Development, and it was exactly on this issue. We all talk about private equity a lot, but it turns out a lot of the financing in nursing homes is actually backed by HUD, and HUD has a lot of ability to encourage quality improvements and innovations. And one of them is smaller homes and private rooms and everything Tamara talked about that could have saved lives during the pandemic that isn't done. And so I would encourage HUD once again, and we wrote a Health Affairs Forefront, Alan, a group of us, including Alice and myself, to say, hey, HUD, do something. And so I wish there was a HUD person in addition to Jean here. Maybe they're glad they're not here, so I could look them in the eye and say, do something, because we desperately need some innovation there on their part to encourage these smaller homes. I do think it's challenging for individual operators to do this on their own, but let's jumpstart this with some action on the part of HUD.
Yeah, and to answer that question, oh, I'm sorry. To answer that question more precisely about, how many deaths could have been saved, I don't think the research is quite there. I mean, certainly size was a factor, and certainly there's some at least suggestive research that the greenhouse models, did a little bit better during the pandemic. I don't think the research is good enough to come up with a number because there are a lot of confounders here. But I would say, yeah, I think there's a general skepticism about the business case for producing these smaller models, right? And so that's where we are. I think there's a lot of agreement that this is a very appealing model that a lot of people would prefer in terms of quality of life. And as we said, there's this benefit of it being sort of a little bit better for an infectious disease outbreak or protection against that. But there's a lot of skepticism about the business case. So I think it'll take these kind of HUD and capital interventions to try to really spur that movement toward that. It's not going to happen on its own. Alice?
And I was just going to add that, Kezia was saying earlier, and you were saying also, how many of these deaths could have been prevented and how can we learn from this? What's the public health learnings here so that this doesn't happen with the next pandemic? And one of the programs we have not talked about yet, but is also funded by the John A. Hartford Foundation and the Jewish Healthcare Foundation, is the Teaching Nursing Home Program, which is being run in Pennsylvania. It's been run for a few years. They're continuing to do work with as many nursing homes in Pennsylvania as they can. There's over 660. But again, a lot of this is about the training of staff understanding the protocols. There was a lot of confusion, obviously, with the last pandemic. And there's also a new leadership and practice book called Leadership and Nursing Practice in Nursing Homes that was written by a few members of the Teaching Nursing Home Group and the Moving Forward Coalition. So we just encourage listeners to think about those kinds of resources because retention and staff support is a big part of this. It's not all about salary and benefits, although it is largely about that as well. So all of those things together.
Great. Just because I don't want to lose it, one question came in that I think just needs to be read directly. It may feel narrow, but it really jumped out at me. It says the role of the CNA is extremely physically demanding. I've yet to meet a person who feels physically they can perform this level of activity for a career. What can be done to develop and fund the purchase of technology to make this less destructive to the caregiver's body? Partly I wanted to read it because we talk a lot about workforce and we talk about work conditions. We've focused on promotion and salary. We have not focused as much on this, and I just wanted to shine a spotlight on it. I don't know if someone wants to answer that question specifically, but I think I, as always, like to use questions as a point of departure to ask, are there other dimensions of a addressing the workforce issue that we haven't touched on?
I mean, I think that they're talking here about physical demand, and there are things like Hoyer lifts that make some tasks a little bit easier. But I think the one point I would also say is the emotional and mental toll. I mean, we are talking about individuals who are helping people who are sometimes have dementia, could be physically abusive, verbally abusive. And, even though you're trying to do your best for that resident, they don't appreciate what you're doing for them. So the thing is, I think looking at the mental health and physical health are things that we need to worry about.
I would also love to agree with that. I was immediately going to raise the emotional toll of this work as well. And I think including the challenges of working in with different residents and different needs, the real emotional toll of letting people go and working through really difficult working conditions, and just the COVID pandemic is such a reflection, like it exacerbated all of that to an almost unimaginable degree for people working in nursing homes. So I think raising this question and just really acknowledging both the physical risks and the emotional risks of this work is the first step, and really has not been done sufficiently yet in order to try to address it. And to the point about physical risk, I would just note that our research shows at PHI that prior to the pandemic, nursing assistants in nursing homes were 3 times more likely to suffer on-the-job injuries than the regular, typical U.S. worker. And during COVID, when COVID became categorized as a workplace illness, they were 9 times as likely. So this is very physically challenging work. And I don't know what the technology solutions are, to be frank, but I think it's really important to be thinking about them. I think certainly staffing, again, is a component. It's one thing that maybe, working with a Hoyer lift can be risky. It's even more risky if you're doing it as a one-person assist when it should be a 2-person assist and things like that. So like everything that we've talked about today, I think it's really about trying to approach it from all angles, including thinking about what might be innovative technological supports in the mix.
Well, let me finish with, sorry, Alice, go ahead.
I was just going to add to Kezia's comments that, part of what we've learned through the pandemic is how isolating it can be for somebody working in a nursing home, owning a nursing home, running a nursing home. And so the peer-to-peer support is something we hear about almost every week with moving forward, where people say, well, which states have done it? Kind of like what John was saying, which states have already done this? Where are the best practices? Because people don't want to reinvent the wheel, but they don't know necessarily how to start. So I would just say the peer-to-peer learning that developed and was really promoted a lot during the pandemic can be something to really reinforce in terms of something that we can continue to do now and is not necessarily really an expensive proposition.
So I have time for one more question. I'm going to broaden the lens one last time, but then ask you to focus in. There are a lot of references to coordination, to planning, to systems, whether it's staff in and out of nursing homes, whether it's the role of nursing homes in public health planning. What I'd ask is that we always talk about the importance of these kinds of coordination. I wonder if I could get you all to be more specific. If you could offer sort of one place or venue where better coordination or planning would make a difference, so that we can move beyond the notion that it's important to here's a place that nursing homes are either included or not. Here's a place where I would hope nursing homes would step in, something to just sort of give that concept of coordination and planning a little bit more concrete meaning. Who could offer me a suggestion there?
I can start.
I can, Alan. I'll go after you tomorrow.
One that I raised briefly in my presentation was, I'd say building long-term care into state and local public health planning, right? Disaster planning. We require nursing home managers to come up with disaster plans. But I think after decades of disasters, not just the pandemic, but natural disasters, hurricanes, etc., decades of seeing even really good facilities that have great disaster plans fail because an individual facility's plan is not that helpful when it's a local or state public health disaster with many moving parts that those individual facilities have no control over, right? So I think that would be a good place to start in terms of helping to avoid coordination, increased coordination, helping to avoid big kind of disasters.
Great. Terry, I think you wanted to.
Just to say that acute care needs to be much more accountable for long-term care. That's where the majority of the dollars are. This notion that there's a disconnect, it can be fixed. And I think that that's an important next move.
I think one thing that you don't see in data is there's a large number of people who go to the hospital, they stay, and then they transfer to the nursing home for post-acute care. And there is a huge disconnect in the communication of what that person needs, what's their medical history, what medications they're on. And a lot of times you see the adverse events that happen in the first couple of days of a nursing home stay is because of that lack of communication. And that to me is exactly what you're talking about, Terry, right there.
That's right. And that sort of circles back to one of those projects that we will continue to work on, which is exactly about that. It's getting the residents, the person's goals and preferences and priorities from the hospital, making sure that data actually gets transferred to the right people who can get it into the record in the nursing home. And so there's continuity there. And also that can be an IT approach where, you know, if there's improved health information technology systems that actually work across settings, interoperability, there can be work where that really helps with coordination too.
I would argue long-term care is poorly coordinated with healthcare, as Terry just made the point. It's also long-term care is each service is poorly coordinated with all the other services along the continuum. Nursing homes have very little kind of communication or contact coordination with assisted living or home and community-based services. You think about this community, this continuum at a state level. All of these areas need attention. We can't think about one at the expense of the other, but we need to think about it as a system. And Alan, unfortunately, we don't.
Jean, I want to make sure you have a chance. Because
I'll agree with many of the points, particularly the planning, the emergency preparedness planning and coordination. I think that's extremely important, as well as as Alice has mentioned several times, and we do this, bringing people in the same room to talk about where the differences are, even between acute care and long-term care, continues to be extremely important. And I'll say to David's point about using enforcement dollars more efficiently, we have started a pilot you may be aware of where we are looking at how we can look at those that are doing a little better quality of care, and that brings about a whole different question to those that aren't, so that we can be more efficient in the use of those dollars. And I'm happy to share that with you as well.
Well, this has really been a wonderful conversation, and it really has been a conversation which I particularly appreciate. So I want to thank our panelists for presenting their work and their perspectives today. Thank the John A. Hartford Foundation for supporting this work, this event, and clearly a lot of the work of the folks here. And I don't usually say this, but I want to thank our audience for submitting some really excellent questions during the event. It made my job a lot easier. As we wrap up, I just want to remind our audience that we have additional events planned for the future. On Tuesday, August 27th, we have a journal club where our senior editor, Leslie Erdelak, will host an event with Benedict Ippolito of the American Enterprise Institute on the recently released article regarding the cost to Medicare of expanding coverage of anti-obesity medications. That event is open only to Health Affairs Insiders, which is a membership subscription through Health Affairs that gives you access to additional content, including events like that one and newsletters and the like. If you're interested in that, please look at our website. With that, I just want to again thank all of the people involved in this excellent conversation, our presenters and their co-authors. And to all of you, I say thank you for joining us, and we are adjourned.